Thanks so much. Hopefully you've got me on your screen now. I would just like to say a huge welcome to everyone. We are so lucky to be able to convene in this way, despite the unprecedented times in which we're moving through, and it's a testament to our community and to the organisers of this day. As Libby says, I'm the University Librarian here at Cambridge, and I could not be prouder of the team here and the work that they're doing, or the way in which our community shares and collaborates during these times to help all of our students and our communities. I would like to give particular praise to them for being so adaptive. We had thought that we'd be here all together. We had thought that we'd be here in person. Of course, that's not how our lives are now. But at least we're walking the walk, and we're demonstrating exactly how you adapt and flex and move with your community, as libraries have done through the ages, in order to support each other and support them. And we are, just as our students are now, and our many community members which we support, demonstrating that remote delivery does work and that we can use it in order to connect with each other and to further our mission and those that need us. This event is brought to us by Cambridge Information Literacy Network, and that's a partnership across the university and college libraries of Cambridge. But I know its work has influence and also learns from many around the country and beyond from our profession, and that's the great thing about how we work together. The network, CILN, Cambridge Information Literacy Network, developed an information literacy framework for Cambridge in 2018, and it is an educational force for good. I can say no less, with thanks to all those who drive it. It is committed to education and teaching and learning, and evidences the value of librarianship and literacy embedded in teaching and learning practice for both educational outcomes and for life skills as well, and both matter. We have two outstanding speakers this morning. We're so grateful to them for joining us at this time. The first is Ruth Carlyle, who I will introduce, and the second is Jane Secker. So I'd like to again just emphasise my thanks for everyone taking time out to join today. The opportunity to learn together is one of the great I think ways in which our community operates throughout all times, but to do so now is ever more important in the busyness we face. So it's my real great pleasure as the University Librarian for Cambridge to introduce Ruth. Many of you will know Ruth Carlyle. She is the head of Library and Knowledge Services at the East of England and Midlands for Health Education England. And I know, just speaking personally for Cambridge, just how much we and our medical library team value Ruth's support and expertise and experience and insights as part of our partnership with the NHS. Our medical library has stayed open throughout this coronavirus, and I would pay testament to them on this call. Ruth could not be speaking to us on a more urgent and timely topic, and I would like to welcome her to give her presentation on information literacy in the age of coronavirus for health and life. Ruth.
Thank you, and thank you for the kind welcome. If you give me a moment, I'll just share the screen through for you. So thank you very much for the kind welcome in terms of this very topical area and our activity around how it is that we support individuals, not just in terms of their behaviours, which is some of the things that politicians are concerned about, but actually the information and the information needs that we as librarians and as library specialists are able to support people through. I'm actually just going to give you a little bit of an overview of how the session is going to work before actually asking you a little bit about what you know already. Don't worry, it's nothing too taxing. It's just giving a little bit of a poll to get some sense of how it is that people view health literacy at the moment. Then a little bit more about what we do in terms of Health Education England before we move into the context in terms of more of the theory around health literacy, information literacy and digital literacy, how they fit together. A classic thing about numbers, how big is this issue? Then an opportunity to ask for first few questions, and then we'll be moving into the more practical things, should we say, in the second half. So thinking about health literacy, the tools, and what it is that you and colleagues are able to do. So I said that first of all I was going to ask you in relation to where you think things are at the moment. So I'm actually going to pass over to Isla for our first poll. So in terms of the poll itself, this is to do with health information. So if you had health information that was purely text, so not numbers, just words, what percentage of the adults aged 16 to 65 in England do you think wouldn't be able to understand? Would that be 7%, 29%, 43%, or 65%? So good to see different elements going through in terms of the poll already. So just giving another moment. So actually not bad in terms of judgment through. Some of you were actually estimating in terms of it being a little worse than it is in terms of 65%, but actually we're looking at 43% of adults are not in a position to be able to understand text-based information in terms of health information at this point in time. So we're now going to move on to a second poll, which is actually when you add numbers. So we've already had one that was just to do with the words. So when we actually add words and numbers, what percentage of adults in England do you think can't understand that health information? So actually we are slightly worse on this than perhaps people were thinking overall. It's 61% of adults that are not in a position to be able to understand information. So we think about what that means in terms of examples for this particular study that we used. If somebody had a paracetamol leaflet, for example, and they were actually looking at what the dosage might be for a child, means that the majority of adults can't understand the leaflet sufficiently well to give the correct dosage of paracetamol to a child. So that's the situation that we're looking at in terms of the scale. So thank you for the poll, Isla. So in terms of what that actually means through, and what it is that Knowledge for Healthcare is doing around this whole area. So as Knowledge for Healthcare, this is the strategic framework that we are using for library knowledge services in the NHS. So as Jessica mentioned in her kind introduction, I work with the library knowledge services across the east of England and the Midlands. So that's 57 of the NHS library knowledge services, one of which is the medical library based in Cambridge that provides support to the NHS. These services we have been working with to make sure that actually they are seen to be key to the evidence base for the NHS. We would all, I think, aspire to having decisions based on good evidence. And that's not just to do with the clinical decisions. These are actually the decisions that are made by boards, by commissioners, by those who fund and make those funding decisions. We would want those to be evidence-based decisions, and we would want to make sure that library knowledge specialists are there at the forefront, making sure that the evidence is being used and understood appropriately. So we've been working to make sure that libraries are very much seen as business critical, that they are informing the decisions, and that we've been promoting what we're referring to as a million decisions, because a million decisions are made in the NHS in England every 17 hours, and we would want every one of those to be evidence-based. We've been working in our first 5 years really to get that frame in terms of the evidence base being seen as critical. And we're now developing for the next 10 years to make sure that we're looking at much more in terms of knowledge management. Some of that's the softer knowledge management. The NHS, as you may be aware, has very high turnover of senior staff. So if you're looking at things like, for example, how it is that you retain some of that knowledge, what you might do in terms of knowledge harvesting, as well as how it is you might bring people together for that learning. So some of the knowledge management type aspects, but we're also focusing very much in terms of health literacy and patient information. Alongside the work that our library knowledge services team is doing, we also work with colleagues who focus very much more on the digital aspect of activity. So some of you may have heard of the TOPL review, and if you haven't read it, I would encourage you to do so. It's actually a very accessible document with lots of different scenarios within it that make you think about what the world might be like in 20 years' time. So what the review was doing was examining the extent to which the skills of the NHS workforce will need to change in the next 20 years. And there aren't many reviews that really do that 20-year forward view and looking at the roles of different types of specialists, and very much a view that actually that future workforce, many of whom will be students now, actually need to have good digital literacy, otherwise they're not going to have e-health literacy. And we would see that information literacy underpins that digital literacy, and that we therefore need to make sure that students, learners have the skills now that they're going to be able to use and apply in the future. But of course, it's not just the learners, and it's not just those who will be working in health services, it's the public, it's the population at large. Because as citizens, if we have an NHS that is digital first, we need to be able to use the resources. So there's a call within the Topol Review for more in terms of partnerships to make sure that we are working to improve health literacy, but also health digital literacy or e-health literacy. And there's much more in terms of call explicitly for knowledge specialists. And the knowledge specialists call within the Topol Review is really about us. The librarian word sadly didn't make it into the review, but actually knowledge specialists is very much about library knowledge specialists and how it is that we contribute within the system. So we are contributing at a time when things are quite political. We may sometimes like to think of librarianship as somehow being neutral, but evidence is never quite neutral. It's always about how you understand it, how you present it, how you use it to make decisions. So thinking about a very topical issue, the issue of the difference between 2 metre social distancing and 1 metre social distancing. So we have a presentation from the Daily Mail, basically taking a piece of evidence from the Lancet and saying that staying at least 1 metre away from people cuts your risk of catching COVID-19 by 80%. Okay, one claim through. And then looking at the same piece of evidence, the same report, The Guardian stating cutting the distance between people from 2 metres to 1 metre might double their risk. So two very different interpretations. And if you go to companies like Full Fact and their analysis, they will say, actually, both are right. Because if you're starting from the point of there being no social distancing, and you increase it to 1 metre, then you cut your risk from 13% to 3%. So yes, 80% reduction. Whereas if you're going the other way around and you're looking at it from 2 metres to 1 metre, then actually, yes, you're increasing the risk by 2.02 times. So you are doubling your risk. It's all to do with how it is that you present the same information. And for all of us in terms of the services that we're working in, it's our nuances, our understanding of that means that we are, if you like, information literate, and that it means that we have the skills to be health literate. But it does have implications for the understanding within populations, because one of the critical things that has come through with this global pandemic is that this is an issue to do with how local populations understand. It's not just to do with individual health. The behaviours that we exhibit are to do with how we work collectively and the impact we have on others. So the COVID-19 pandemic has therefore highlighted that poor health literacy among a population is an underestimated public health problem globally. It's not just that we don't necessarily understand within our own communities, it's that we get further confusion when we look at information that may be interpreted slightly differently within other communities, and we need to understand what that means for us. So a complicated time. And in terms of the team that I work in, within Library Knowledge Services in Health Education England, we've been making our own small contribution to this work in terms of our own direct activity. So we would always be supporting library knowledge services in the NHS. And as part of that role, we have a blog site, which is our Knowledge for Healthcare blog site, and we've brought together evidence sources. We've brought together things like searches and an expert group to review those searches to make sure that we're reducing duplication in the system at a point when actually NHS library services have been phenomenally busy, not just with the coronavirus information requests, but also the complexity of the day-to-day searches have a new layer because actually they're to do with the safety at the same time as actually what you might be looking at in terms of your usual evidence base. We also, as a team, in consultation with Public Health England, NHS England and Improvement and others, discovered that we felt there was a gap in the resources that were being made available to the public. Some of you may be aware that under the Accessible Information Standard, there is a legal right for any individual to receive information in a format that's suitable to them. So that might be, for example, British Sign Language, it might be Braille, etc. Might be easy read, and often it's easy read that's a useful resource for people. So we all as individuals have a legal right to accessible information. Unfortunately, we don't have a legal right to accurate information or to evidence-based information, but we do have a legal right to accessible information. But there was no one point at which this accessible information in terms of different formats was being brought together, so they were easy for NHS staff to find or for members of the public to find. So we've brought together the resources that are being produced in terms of where they are high quality and accurate accessible formats, but also brought together resources that are for specific conditions. So not just people who are vulnerable and shielding, but actually people who may be concerned in relation to scenarios through. So we've just in fact put up information about cancer. We'll be putting up information this week in relation to long-term conditions. So gradually expanding out the resources through on that site. So we're signposters. I would think we are all good signposters, and signposting is not just about how it is that you make sure that somebody's aware of something, but how it is that you tailor the approach of what goes through. But we also share skills, and I think this is where it's not just health librarians, but across all sectors, we have very, very pertinent skills. Because what we are doing is we're actually sharing what we do normally in terms of our literacy models and our literacy working. I confess to being a great advocate in terms of the Cambridge Information Literacy Network model. I think that your framework for information literacy is a very powerful one, partly because actually you can see how it relates to other literacy models and how it is that the work that's done around information literacy is absolutely core to any other skills that people are developing. So if we think about the model in terms of the information literacy, so you're looking at the resource discovery, critical assessment, managing information and creating in communications. That already begins to tie into some of the work around digital literacy that was developed initially by JISC, but Health Education England has further applied and is developing a self-assessment tool so that individuals can work out at different points in their career or in their lives what their digital literacy level is. And so the 6 domains to this in terms of the digital identity, communication, teaching and learning, information creation, and technical proficiency. And then alongside, and we will spend a bit more time along this later, we have our health literacy. So some of this is about function, and some of it's to do with critical skills, some of it's interactive skills, and that may be the area that actually may be less familiar to individuals. So if we're aligning those models, I would suggest that almost all of what exists within what we call digital literacy and health literacy actually is encompassed within information literacy. And information literacy and the work that library knowledge specialists do to develop information literacy is an absolute core skill on which these other areas are then dependent for the future. So there are some aspects in terms of digital identity that may or may not be covered within information literacy. I think in some models it is, in some models not, but it could be something that you think of as being specifically around the digital domain. There is also something about technical proficiency, and that technical proficiency changes over time, is not necessarily about a core competence. It's much more about an ability to adapt, to have the skills to ask the right questions so that you can develop the proficiency you need at a particular point in time. And then on the health literacy, I think there is an interactive element that is slightly different from what we would see as being the information literacy core, but is still very closely aligned. So what do we mean by health literacy? Well, as with so many things, there are lots of different definitions around, and some are wordier than others, and some are clearer than others. Fundamentally, it has the dimensions both of the system, so what the system provides, and the individual and the individual's skills. So it's about how it is that people have and the system enable access, understanding, appraisal, and use, which probably sound very familiar as concepts with many of the things that you're doing around information literacy. The World Health Organization, in terms of its definition from 2015, talks about the personal characteristics and social resources needed for individuals and communities to access, understand, appraise, and use information and services to make decisions about health. There is an earlier definition from the World Health Organization from 1998, which does put a little bit more focus on personal responsibility. And it tends to be this newer definition that we would use, because it's partly about how we as members of the system can enable people to access information. After all, it's not an individual's fault if the text is written in a way that is too complex for them to understand. There is something about how it is that the system makes sure that information is presented clearly and easily so that people can access it. So we talked about the scale, and we talked about, actually, in terms of when it's words, an average of 43% of people, this is between 16 and 65, do not understand. There is a bit of a north-south division, with the exception of London, but it's not just in terms of north-south. And we don't think that suddenly, magically, as soon as people turn 66, their health literacy improves. It's that, sadly, we don't have data for the 66 and above. It's just that the data that we have are for the 16 to 65-year-olds. And it is possible that actually people's health literacy actually deteriorates as they get older, as opposed to necessarily being any better. So I was planning to come over to Cambridge today, so I thought I would do a little bit of a view of Cambridge in terms of what the perspective is locally. So Cambridge, well, we're looking at an average of 43%. And yes, quite a lot of Cambridgeshire is doing better than that. But if you look at the north of the county, actually, no, it's worse than average. And even the figures that you have are not brilliant in terms of people not being able to understand. And where you sit within a national range, actually the place that comes out as being the highest level of health literacy is somewhere called Hart in Hampshire. And the lowest is actually Newham in London. So quite a range through, and you're midpoint through, but still not brilliant. And then if we look at our numbers to do with the words and numbers coming together, so what our literacy level is, as you may remember from the poll at the beginning, it was 61% of people not understanding. So again, we have a bit of a north-south divide, and actually you seem to be mirroring the north-south divide in Cambridgeshire as well. So slightly better figures than the national average, but nonetheless, if you're thinking about this in terms of the paracetamol example, if nearly 36% of the adults in Cambridge can't understand a leaflet sufficiently well to give the correct dosage to a child, we actually have a major issue in terms of how it is that we're making health decisions ourselves, and how it is that we as librarians are supporting others to be able to make those decisions through. But this isn't just a situation for England. So this is an example from Germany. So Germany used slightly different modelling and slightly different measures, but they still estimate that actually 54% of adults have limited health literacy, and that it's only 7% of adults have very good health literacy. If you look at US models, you'll find that they are different again. And in the United States, of course, we have the complication of needing to have financial literacy as part of your health literacy. Because if you don't understand how your health insurance works, then you don't know what choices present you. So just thinking a little bit about the implications of all that. Well, I suspect quite a few of us have seen signs a little bit like this in the last few months, usually scattered along the floor at what one hopes are possibly 2-meter distances on our shops, etc. But how do people really understand this? For some people, would 6 feet be clearer than 2 meters? Do they understand that it's 2 meters in all directions? So if you've walked past somebody at a 2-meter distance, you have to stay past them at a 2 meters distance, not just cut back in front of them. And then we have further complications in terms of some of the statements this week. So I'm going to read a statement that came through from the Prime Minister on the 23rd of June. Where it is possible to keep 2 meters apart, people should. But where it is not, we will advise people to keep a social distance of 1 meter plus, meaning that they should remain 1 meter apart while taking mitigations to reduce the risk of transmission. Now, not straightforward for many people who are confused in terms of meters, distance anyway. Does it really mean that actually we're still sticking to 2 meters, or that actually 1 meter is okay as long as you're taking mitigations, which it's not stated of things like a mask in this point. So there are all sorts of issues in terms of implications for individual health, but also at a point of pandemic for the health of the community if individuals are not in a position to be able to understand. So I'm actually just going to pause now in terms of seeing whether there are any questions that have come through on the chat. Unfortunately, I'm unable to see the chat, but Libby is able to do so. And then we'll go on to a little bit more in terms of the practical elements through. So I don't know whether there are any initial questions.
There are not a huge number of questions at the moment, Ruth, but there's a question about whether we can be kept informed about the progress of the assessment tool for digital literacy.
Absolutely, and very happy to involve people in that. And one of the things that I'm delighted to have within the tool itself is that actually you can indicate what profession you belong to, so that actually we can get some sense over all different professional groups. And library knowledge specialists are a professional group within it, so we can get some sense of how we ourselves rate and how it is that we can improve ourselves. So I think it would be really good to get it to keep colleagues involved in terms of that tool as it's rolled out. In terms of its current status, it's currently in alpha. We should have the public beta November this year.
Thank you. There's a question come through about the statistics, the literacy and numeracy statistics, and where they've come from and how recent are they?
Okay, so as many people will be aware, we don't necessarily get national surveys that are conducted as frequently as we would like. This is the Skills for Health survey that was conducted in 2011 with a 2016 projection which has been applied on top of it. So this is analysis that was conducted by Graham Moon at the University of Southampton. So not as good as it could be, but it's the best we have at the moment. We are hoping that World Health Organization Europe may be funding some further work in terms of health literacy across all age groups that would include England as well as including the rest of Europe, which would be fantastic if they're able to do so. Clearly, at this point in time, anything that involves new expenditure is a little subject to future debate, just because of the situation that we're in currently, but those are where the data come from. So you'll see within the handout, and when you see the footer of the slides, that there's actually a click through that you can do in terms of the geodata, and that actually gives you further details in terms of the information sources if you click through on that, as well as the details for any particular local authority area.
I should mention that the handout will be coming out. It hasn't been sent out yet, but it will come out. There were a couple of comments. I mean, you may wish to comment a bit more about, but more comments rather than questions, but particularly about the change from 2 meters to 1 meter, and a few comments, perhaps rather than questions, about that coming through on chat. I have a question from Jane Secker that she would like to ask us how library and information professionals can make themselves known as trusted people. It may not occur to many people to ask us about health literacy and stats. For example, she has a lot of family who keep saying they're confused but don't seem to know that she could help.
I think there's an opportunity and a risk actually also for library knowledge specialists that we have to be seen as part of this area, and that actually information literacy is fundamentally about how it is you judge the bias of sources and those sorts of areas, and therefore we should be the key people come to. From a Health Education England perspective, and we are in discussion with CILIP, so our Chartered Institute of Library and Information Professionals, and others. We're hoping to start a 5-year programme that we would be very, very keen to involve academic libraries, school libraries, all other sectors in, to be able to look at how it is that we promote the role that we already play, how it is that we share tools and resources to make sure that there's greater awareness around our role in, should we say, digital health and information literacy, that trio of different literacies, which I think come together very closely, because there does need to be greater awareness in terms of the activity, and perhaps sometimes a little bit more confidence and sharing in terms of communities of practice as to how it is that each of us in different sectors is working.
Are you happy to take one more question now, Ruth?
Yes, you can take one more.
A couple more. So one more coming from Alison Hicks. Can we really talk about accuracy of information when so many COVID studies are ongoing, as well as being retracted, changed, updated?
I think it's a very fair point, Alison. And I think a lot of it is actually making sure that people are aware that this is the current as we know it, and these are the boundaries within which activity is taking place. I am very disconcerted by the way in which sometimes things are presented as if they are fixed. whereas we know that knowledge actually is always constantly moving, and part of our role as professionals is really advising in terms of this is the current status, keeping things updated ourselves, but also in terms of how we present information. There's our own personal responsibility around how it is that we make sure that it's clear that this is what we have used as a source, and this is the dating of the source, and that the source itself may change, never mind having new sources that are coming through.
Thank you.
So thank you for the questions. So we're now going to move on to the more practical bits and pieces, which I promised earlier on. So thinking about types of health literacy. So I mentioned very briefly on the earlier slides when we were looking at health literacy, information literacy, and digital literacy and how they want to link, that actually there's this element to do with functional health literacy. So this is the modelling that was produced originally by Don Nutbeam back in 2000. He refers sometimes in his texts to types of health literacy, sometimes to levels. And he has suggested that sometimes you need to have a functional level and then move on to an interactive and then to a critical, but they are not fixed. They will vary at different points in time, and we'll come back to the fact they're not fixed. So your functional, how it is you actually find it and how it is you apply it in basic level, and we'll use some more examples later. The interactive, which is perhaps the area that you're not working in so much at the moment, but more in terms of how it is that you work out which are the points that are relevant for you from a document, or how it is that you might think about the questions that you need to ask, how it is that you might prepare for a consultation in terms of the key questions that you might want to have after reading a leaflet. And then critical, which is partly, I think, our classic critiquing, our critical appraisal skills. It's sometimes described in terms of being about gaining control because actually you know what sources you're using, but I think it is fundamentally to do with our critical appraisal skills. So if we're thinking about how it is that we're aligning the skills that are classic librarianship and information skills to health literacy, well, the critical is very much our skills in terms of appraisal, how it is that we assess bias. Functional, I would say some of the absolute core and lower level information literacy and digital literacy element. And it's perhaps just the interactive that has a slightly different aspect in terms of comprehension of content and awareness of questions to ask. So in terms of how far are you using health literacy? Well, we are all using health literacy in the decisions we make day to day, and we're perhaps more conscious of that at this particular point in time with COVID-19 than we would be in other times. There's something about how we read appointment letters, understand the time and follow medications guidance. So classic issues tend to be, the NHS has a genius for changing the name on a building, but not changing the name of the building in the letter. Or you might have something like a description of going to the X-ray department, but actually when you look at the signage in the hospital, it may be described as radiology or imaging. And how can you necessarily follow those through? So there's something about making sure the system keeps things clear for the functional as well as the individual. It's not just for individual responsibility. Then the interactive, that's really to do with how you might take content from different sources to make decisions. So it might be that you're looking at literally your paracetamol leaflet, but you might also be looking at things in terms of issues to do with pain management more widely, or fever control, and using other sources alongside the leaflet that you've got in front of you. And then critical, that's the ability to read and to challenge the information and challenge the sources in terms of actually, was this current? Is it something that actually is unbiased? Who funded it? All those classic things. And that actually, for 1 million decisions, we actually have with 17 million decisions every day, we have the opportunity to make sure that our colleagues are around and are aware of what it is that we do and how it is that we work, not just in the NHS, but elsewhere, in terms of our ability to support and to critique. So whether it's the NHS, 1 million decisions, or whether it's other campaigns, to make sure that others are aware of what it is that we do. So what does this mean if we're thinking about evidence-informed decision-making, whether that's individual, whether that's organisational? Well, within Health Education England and others, we've been working with our 1 million decision campaigns with a range of different stakeholders, people who we would see as being key to the profile of evidence-based information. So this is Trish Greenhill, who many of you will have come across in terms of her working through, and who's come up recently a lot in terms of the evidence she's been bringing to bear in terms of masks and whether or not people should be wearing masks in public, for example. But she is one of our advocates in terms of having evidence-based support. She's also known in terms of her authorship of How to Read a Paper, which is perhaps the guide to evidence-based practice that many people are using. So when it comes to evidence-based practice, she wrote the book. But actually, I did say that levels of health literacy change. So when she herself was diagnosed with breast cancer, she found her own health literacy going down. So I'm a professor, yet the first thing I did was I put breast cancer into Google because you're frightened. And I think that's a critical factor for all of us to bear in mind in terms of looking at the functional, interactive and critical health literacy, is they're not fixed. At a point of stress, at a point of shock, actually people's levels do go down. And that there is an element in terms of actually making sure that we ourselves retain an awareness of where we sit, but also in terms of those around us. So this has significant implications, both in terms of the level people are at and where they actually have moved to because of shock. We get all sorts of misunderstandings, poor decisions, exacerbated inequalities. And I fear that we will get yet more exacerbated inequalities in terms of people's understanding of situation at this point in time. Inappropriate use of medication, which of itself can have ramifications for people's health and well-being. The fact that actually people don't have effective access to health services at a really basic level. If the letter was written in a way you didn't understand and you didn't feel confident to challenge and to ask, you might not attend that key appointment. You might not have that key diagnosis in time for it to be treated effectively. So there's all sorts of things about access to health services and then poor health outcomes for individuals. But I suppose the good news is that we as a profession can help. So some of it's to do with just using some of the basic tools that are already available. So again, this will be linked in the handout when you see it, but also there's a link through from the bottom of the slide when you get the slides. So this is a how-to guide in terms of health literacy and the roles that we can play. The guide is actually part of a suite of resources. So the suite of resources includes guidance on how to make a business case, because quite often you might need a bit of money to do something or change how it is that you allocate resources to do something. It includes case studies, training materials. But the how-to guide itself gives things like general definitions and the sources of those definitions, guidance in terms of general communication, verbal communication, and written communication. So things about style, design, print, use of pictures and symbols, just to give a starting point in terms of what resources you might be able to work with them and how it is that you might appraise the resources that you refer other people to. As a team within Health Education England, we've just started to promote a model and scale of sharing in terms of health literacy training. So we've started off with what has been in-person 2-day element in terms of our top of the triangle. So people who actually need to be able to train others and to do a significant amount of training others. And we're working through in terms of how we can do the equivalent of that in terms of being remote as opposed to in-person. We then have a full day awareness training, a 1-hour session, which we've actually worked on in terms of accreditation with the Royal Society for Public Health. 15 minutes, because quite often, particularly in the NHS, we do have 15 minutes with, say, junior doctors in terms of induction, and I'm sure the same applies in terms of whether it's a school or whether it's in terms of an academic library, that actually others will be doing some very short inductions and just need a little bit of information to be able to provide and get people to come back to. We've also produced and launched in April this year e-learning for health literacy. So this is a 35-minute programme that we developed with NHS Education for Scotland, drawing on some of their very high quality materials. It produces for people a mechanism whereby they can actually then assess their training. So the 35-minute programme includes your action plan in terms of what you might put into your CPD file and gives you some pause for reflection through It covers some of the core techniques in terms of things like chunk and check and teach back, which I'll talk about in a moment. But I think in terms of giving people an introduction, it's a good signposting tool for you to refer others to, but also maybe something that you consider using yourselves. It's been designed so that it can be accessed by anybody, but if it is somebody who's using it within the NHS, they can have it so it's added into their staff record. So it is a resource that's available to the public and pitched so that it can be used by the public as well. So in terms of different mechanisms, so the first one is to do with teach back. So if you haven't understood what I've been saying, actually, that's my responsibility. It's not your responsibility. There may have been some other distractions going on in the background whilst you've been sitting and listening, but actually, it is still my responsibility to make sure that what I provide to you makes sense. So the whole sense of teach back is that actually the communicator takes that responsibility. It isn't the responsibility of the person who's listening to make sure that they understood. So you may ask, for example, how would you explain to your family and friends what decision it is that you want to make? How is it that you might explain to somebody else? So it isn't about have you understood type questions. It's more, how would you tell your children about this? Or how would you tell your employer if it's something you'd need to talk to your employer? So a ways of actually asking people to tell you back, teach back what you said to them in a way that actually makes sense for them. And actually, if it wasn't quite right, then actually you re-explain, or you find different ways of using analogies. You might use pictures, you might use videos or other resources, but actually that you continue to explain until you're happy that both parties understand the same thing. So that's the teach back. And although it can sound very time consuming, actually, particularly in a health setting, if it's used well at the outset, it means you don't get lengthy discussions further down because actually people haven't understood and they're needing to change their behaviours. Alongside this, we quite often use chunk and check. So in a face-to-face, and particularly in a one-on-one situation, you would tend to be thinking about a short piece of information and then actually checking how they've understood it, as opposed to, I'm conscious I'm speaking for quite a long time. And we wouldn't normally in our day-to-day conversation have a half-hour section or a 25-minute section and then pause and then another 25 minutes. We would have much shorter sections. And then just make sure, are there any questions, or what questions do you have for me? Which is the much more health literate question, because actually everybody should have questions, because there will always be different ways of seeing things. Thinking about written communication and how you assess what it is that other people have produced. Lots of things are to do with having short sentences, using lists when appropriate, active verbs, appropriate language, and things like the crystal mark can help in terms of elements through. But just thinking about your own services and how it is that you make sure that they are what we would describe as health literacy friendly, but probably also information literacy friendly in the wider context. There's something about the written communication within the library knowledge service itself. So actually, what guidance do you have to staff in terms of the written communication and what's used on signage, what's used in terms of user documents? Have you user tested it to make sure that actually people understood it? Do you have a policy in terms of how it is that you write communications? So, and then your spoken communications. So things like, do you actually have a standard way of answering the telephone? Or how it is that you actually describe the service so that it's clear to people what you're talking about and what it is that you do in terms of the offering of help. Because if you offer help to everybody, then it doesn't become an issue. If it looks as though you're targeting health to people who feel as though you think they need it, that's much more likely to be an issue for them. Then there's the stock in terms of health and wellbeing information materials, either things that you hold in a range of formats yourself or how it is that you advise others. And we've just started work with the reading agency in terms of a health and wellbeing book list that we hope will be relevant for particularly NHS staff, but I think also in terms of staff more widely. Then, that practicality of signage, just regularly reviewing, has that building changed its name? Actually, are you able to find things clearly? Have you tested again with library users in terms of whether they could find things within the library itself? making sure that training actually includes, whether it's health literacy awareness in our case, or whether it's more widely in terms of information literacy awareness, to make sure that staff are acting in a way that is information literate and we would hope health literate, and then making sure that we've got training that's appropriate to the roles of all staff that's being offered. And finally, policies. So you may not have a health literacy policy for the service, depending on where it is that you're based, but actually you still need to make sure the policies that you have reflect what might be needed in terms of being a health literacy friendly service for the future. So in terms of activity now, in terms of NHS library knowledge services, we are certainly doing our work in terms of looking to spread training, etc. We've also, as I mentioned, started the process of developing new partnerships for what we hope will be a 5-year programme, really to look at what's the role across the system that library knowledge specialists in different sectors play in terms of the interrelated health, information and digital literacies, and how it is that we collaborate, support each other's learning, as well as supporting the public. And at a very practical level, some of you will be aware that actually it's Health Information Week between the 6th and the 12th of July. This year it's largely virtual, but it's focusing very much on skills around finding high quality information and also support around well-being. Those are our 2 key focuses. So it may be that you're not involved directly yourselves, but do look out in terms of the HIW 2020 hashtag, do follow in terms of discussions through, and it may be that it's something that you would want to contribute to in future years, being always in the first week of July. And it's a nice, easy way to start a conversation between different libraries working within different sectors. So just before I close, I would actually like to make a personal dedication for this discussion. We mentioned earlier, these are very strange times. So I would like to dedicate this talk to my father-in-law, who very sadly died of COVID-19 on the 22nd of May this year. These are times that impact on all of us, and sadly, I think will continue to do so. And so just to close in terms of that health literate question, in terms of posing, what questions or comments do you have? So Libby, hopefully there are some questions that come through.
Sorry, I'll just unmute myself. Thank you so much, Ruth, for that presentation. And we definitely have some questions that are coming through. There were a couple further back in your talk, starting to ask questions about information literacy and what we actually might call that. So there's a question about, is there any other term we could use to describe health literacy information skills training? I think literacy, illiteracy has negative connotations for people, and alongside that someone suggested using the term information fluency instead of information literacy.
That's a nice one. I like that. Yes, and I would concur that we use the term health literacy just because it has, I suppose, resonance with the literature, with what exists elsewhere. I don't pretend to like it as a term. So yes, but the fluency is interesting. Thank you.
Yeah, so there's obviously some conversation about that. There's another question about what do you think are the main information literacy skill you think we need to help today's undergraduate medics need to master?
That's an interesting question. I think there is something about understanding bias in sources. Some of the discussions that we've had through in relation to, for example, Health Education England funds a tool which is BMJ Best Practice. It's a resource that basically structures content so that it can be used at the point of care. So it's not a search engine or as such. What it does, it structures content so people have information they could use. And one of the things that we've found quite interesting when we've been working with medical trainees and others is that actually people don't necessarily understand the difference between that sort of tool and doing a search in a database or a search in Google, and actually that there is something about people understanding where there are biases and where there are restrictions on the content types that they're using. It has particularly been an issue where it's things that are pharmaceutical funded, and whilst you would think that actually people might register, that there's just something that they need to think about in terms of that sourcing. It's not always the case, so that there is something there. But I'll do some more reflecting on that. I think it's a good question. Thank you.
There's a question from someone asking about what opportunities there might be for employees in care homes to be trained in communication and health literacy.
I think there's huge opportunities. In fact, I've been having discussions just this week with NHS England and Improvement, who have been doing some work around digital navigators and digital champions to support work in care homes. There are some resources that are beginning to come through. Some of the resources that have emerged have been largely podcasts, actually, but also some services, particularly in the northeast of England, have actually had buses that have gone out to care homes to be able to provide a suite of different training, should we say, nuggets, short sections, which would include things around information literacy, but also other things. So one of the core things that very sadly care assistants have been having to be trained on at the moment is things like how it is that you hold an iPad for that end of life conversation when the family can't be close. So there have been some integration in terms of some of those tools through. I think NHS England and Improvement are keen to make sure that we have better support generally for the care home sector in the future. And I would imagine that one of the things that is likely to come out from the wider changes in terms of health and care is that we will have to have a closer relationship across the educational support, because it's become apparent to those to whom it may not have been apparent just what critical roles the care workers within care homes are playing and have been playing for many years.
Yeah, absolutely. I'm just scrolling through, check for more questions. Let's have a look. Yes, so there's another question here about librarianship as a profession. We are prone to using opaque language, apparently, which is true. I think every its own language, doesn't it? Are there resources out there with guidance about library signage, language on websites or library guides that you're aware of? I'm sure there's plenty on there.
I'll come back on that. One of the things that Libby mentioned earlier was that I'm happy to respond further to questions. So I will look at that in terms of the questions that come through, in terms of making suggestions through. I can share what we do in terms of some things within the NHS sector. I'd need to check more widely in terms of what exists elsewhere.
Okay, thank you. I'm just going back just to check through on chat to see if there's anything else. But if there's any other question that people want to put into chat, please do, and I'll just pick them up. I'm
going to jump in with a couple that I've picked up, Libby, on the side. There was a recognition from academic librarians about the issue of emotion that impacts onto understanding, and obviously we're, as academic librarians, we're very familiar with stressed out students at various stages of their career, so the impact on their ability to retain or to hear information at that point of stress is something that rings true with a health stress situation as well as academic. So there's parallels in different situations. It's not just a health literacy thing, there's an emotional understanding thing. But there was a point raised by a couple of people about the opportunities to insert health literacy training for students, for healthcare students, because they're getting them when they're professionals is great, but getting them when they're young is better.
Oh, absolutely. And certainly it would be ideal if we could get some elements through. Health Education England doesn't actually do the curricula, sadly, for the different areas. So a lot of it's about influencing in terms of trying to get areas through with insertion. And quite often it is things like library inductions that become, should we say, the more flexible elements through. We have some, interestingly, it's actually GPs who are beginning to become more interested in having core elements on health literacy earlier in their training, because I think they are, once they get to a point of actually practicing, they realise they should have had it earlier and are much stronger advocates than perhaps some of the other professional groups. So if general practitioners want to have it, and then we can do more in terms of, should we say, the wider training, that's a good element through. There are some of the new medical schools that are actually incorporating it through from the outset. So Kenton Medway is beginning as a new medical school from September this year, and they are looking at digital and health literacy as being a core strand not just as a separate module, but to integrate across throughout each year of the training. And if over time other medical schools and other training institutions start to do that, I think that will be very powerful.
Thank you. Just checking, we may have time for just one more. It looks like there's a question for the UHMLG, which I think that might be for Isla, more in terms of health literacy for students. And just checking for the final set of questions. Just one final question here. We've been made more and more aware of the impact of non-medical professions in healthcare as the pandemic has been going on, cleaners, admin, etc. Any thoughts on health literacy education for these people?
Sorry, could you repeat the question? Sorry.
So we've been made more and more aware of the impact of non-medical professions in healthcare as the pandemic's been going on, such as cleaners or administrators. Any thoughts on health literacy education for this sector?
I think definitely it needs to be more in terms of support for health literacy education. We've actually, one of the things that we found interesting with the usage of some of the easy read coronavirus resources, for example, is that we've had quite a lot of local authorities and others come to us because they've wanted to use it for street cleaners and to make sure that it's available for people who are really very, very exposed and just need to have basic understanding through in terms of support. So there's something about the resources from the system, but I think there's also something in terms of the training and the skills. And there is a sense in which actually people who are in non-clinical roles are very much a front line that people talk to as well. So their awareness of actually, if they're a porter or whatever, what their parameters are, I think it would be very powerful in the future.
Thank you, Ruth. I think I'm going to draw this to a close now. We're just coming up to 11 o'clock, if that's okay. There are a few more questions that are coming through on chat, and Ruth has promised to have those for sure, and we'll get some answers back up with all the rest of the materials alongside Ruth's slides, the handout and so on. Ruth, thank you so much for your presentation. I mean, one thing I particularly spotted myself and I've taken away is your teach back slide, and just how much the communicator has to take responsibility for ensuring that people have understood. And I think that's a lesson for all of us, regardless of our background, regardless of where we're coming from, regardless of who we're engaging with and talking to. And I thought that was a very powerful point. So thank you very, very much.